Next is Ms. Capps.
Thank you, Mr. Chairman, and I want to use my time really well with great panel, and I have a question for each of you, starting with Ms. Pipes. In your testimony, you talked a lot about rationing care and waiting lists, and Canada does have bad wait times, but so does the United States. 23% of adults reported having to wait over 6 days to get an appointment to see a doctor the last time they needed one. In the UK, which also has a single-payer system, it was only 15%. In addition, 34% of sick adults in America who had medical problems skipped important doctor visits because of cost. That's way more than the 4% in the UK and the 7% in Canada. Not to belabor that, because we're talking about American system that we want to try to reform, is there any data you can present to this committee showing that a new optional public health plan will create rationing times or wait times worse than what we're seeing right now?
Well, I haven't done the exact research on that particular issue, but I think
so there is no documentation that you know of?
Not that I know, but I can look into it and find that out.
That would be great. If you can find it, I'd love to have it for our...
Because I think, you know, Canada does have long waits, and people that have money come to the United States and pay out of pocket.
You said that in your testimony.
So it's very important that we improve the U.S. system so that people can get better access. And that's why I support universal choice, because a young man of 30, you know, wants to get a high deductible insurance plan. Why should he have to pay $12,000 to $15,000 to cover my in vitro fertilization? You know, I mean...
Thank you very much. And if you can find that information for us, I think it would help us to make some good decisions. Dr. Fader, I mentioned a story in my opening minute about a constituent of mine who lost her job and had a reoccurrence of her cancer. She did well in the county that I represent because they have a particular public access program that worked for her. But I want you to be able to elaborate briefly, but for our value, what you were saying about how when someone loses employer coverage, their ability to purchase coverage in the non-group market is limited at best.
Yeah, well, it is. You're absolutely right. In your community, she had an option. She had what is called a pre-existing condition. She was sick. And you're going to hear on the next panel from my Georgetown colleague, Karen Politz, who can give you examples, a tremendous number of examples of this kind, that people in the non-group market essentially does not either denies people who have conditions, rules out coverage for the body parts that have been damaged, limits the benefits, or charges higher rates. The market simply does not work for people. It's not any kind of safety net, and the evidence on the non-group market is that rather than people falling into that system and getting picked up, it ends up people are healthier in that market than in the employer-sponsored system. So this woman, without your plan, when she most needed care, would have lost any means to get access to it. And we know, looking at the evidence in general on the uninsured, that people are actually dying in that circumstance.
Thank you very much. And
people do. I mean, I think if we change, because people get their insurance through their employer and it's not portable if they lose their job. This is one of the reasons why changing the tax code so that people can go into the individual market. And also, I think we'll see more competition and new insurance companies that will deal with specific people.
We'll see about that.
They don't compete. They don't compete for sick people.
That's right. If there's anybody who can show a plan where they compete for sick people, we would love to hear about that too. There's another topic that's very dear to my heart, Dr. Reinhardt, I saved for you. In the United States, we spend nearly $7,500 per person on health care. It's the most expensive system in the world, if I'm not mistaken. Yet, in terms of maternal mortality, women dying in childbirth, we rank 41st out of 171 countries. So there's a disparity there. How can we now, as we want to design, reform our system, what are some proposals specifically that would improve issues like maternal health, a classic indicator, according to the Millennium Challenge, for the overall health of a nation, while striving for lower costs?
Well, obviously, part of the reason why women die has to do with issues outside of the health system, and every health services researcher would recognize this. But when you come to infant mortality or maternal death, the health system does have a contribution to make, and I think we're falling short. It's because people often do not have insurance, particularly when you're just slightly over the Medicaid limit or live in a state with a low threshold. And I must say, as a European and ex-Canadian, I'm stunned at this. I believe the children are the treasure of a nation. They're the future generation. And I always have said, to me, mothers are on par with soldiers. They do a patriotic service because they bring us the next generation. We should give them medals rather than the way we treat them. And I remember I once gave a speech called Motherhood and Apple Pie, where I said, I do buy the idea that Americans love apple pie, but I'm not so sure about motherhood. I don't think in this country we respect mothers enough, and I have people who know me know that's a big deal with me. We do not respect mothers enough.
It'd be worthwhile you looking at some of the work that June O'Neill has done on infant mortality rates, because other countries, we have the best neonatal, what they just count as infant mortality rate versus this country, because we keep a lot of babies alive that wouldn't even be counted as live births in other countries. So it's very important. Look at June O'Neill's work on this issue.